Uploaded this. So you guys see it on the okay, good. So again, this is a little bit of rehashing from some stuff we talked about in pharmacodynamics, but I think, or the intro to Clinton Farm. But I think this is good because now you have context. Right, now you have a much better idea about how drugs work, what different drugs are, and we can kind of talk about this from a more kind of educated sort of standpoint. So here we're going to go over some of the concerns we have with things like for pediatric patients, geriatrics, and then kind of some finishing up with some RX prescription stuff to make sure you guys are all kind of up to the letter of the law. You guys are already experts at writing prescriptions, but just some things I'd like to reiterate before you get out there in the clinical world. So starting with pediatrics. So again, peds are just little adults, right? Well, children, no, they're different, are they? Oh, I've been doing this all wrong this whole time. Just kidding. No, they're very different. So remember, they're a very heterogeneous population. So dealing with a 1,500 gram 2-day-old born at 24 weeks is much different than dealing with a 16-year-old patient, right? Very different patient populations here. And so it's important to understand what those physiologic changes that are happening so you can kind of understand why we're doing different things, why we're using different drugs, why we're dosing drugs differently than you might see for an adult patient. Other problem is that children are hard to do studies in. Like, they're a protected class because they can't really consent to being in a study, right? So again, a lot of these things we're taking data from adults and trying to extrapolate it back to children, which I already mentioned is kind of fraught with issues. Or we don't have a ton of like really good studies to show that yes, this is a really good drug for them, or what the best drug is, what the best dose is. So again, it can be kind of difficult. And so some of the things we'll talk about here, just some of the general lingo. So we mentioned gestational age. What does that mean? Yeah, how long they were cooking for, right? So how long they were in mom. At the postnatal age, which is basically what? Chronological age, right? They came out, and then there's a post-conceptional age, so basically it's kind of the both put together there. Most frequently, though, especially in the NICU, in the neonatal intensive care unit, we talk a lot about their gestational age because that will give us a very good clue on what? Just how developed they are, right? So again, someone who was born at 24 weeks was kind of like one of the earlier viable birth age, or gestational ages there. Their body functions completely different than someone who was in cooking until 38 weeks, right? Their kidneys are far different. Their body composition, body water, everything is very, very different between those two. And so it's important to talk about gestational age because a lot of dosing for different medications will rely on the gestational age. So I'll see something like if I look up, say gentamicin on Lexicon or some Micromedics or wherever, it'll say, hey, was their gestational age less than 34 weeks or greater than 34 weeks? And dosing is pretty different between the two. So these are things you need to kind of keep in mind and make sure you're looking at before choosing a dose for your patient, especially if you plan on dealing with these patients with some regularity. Again, preterm is anything less than 37 weeks, usually full term 37 to 42. And then usually when we're talking about neonates or newborns, that's going to be that first month of life or that first 28 days, right? So again, certainly we'll have kids that are in the NICU for several months, especially those that are born really early and they're still kind of, they just need that kind of extra support until they can kind of, live on their own. However, that neonate period is really that first month there. And then an infant would just be kind of that full first year. I'll probably refer to lots of technically neonates as infants. That term you can kind of use interchangeably, but newborn, neonate, that's really that first month there. Toddlers, kind of 1 to 2 years of age. I'm dealing with a toddler right now. Let me tell you what, it's like dealing with a bipolar patient who is drunk and suicidal. She's in her climbing stages now and trying to climb on everything, and then she's like, you got to get me down. I'm like, get yourself down. She's like, no, you're going to get me down or I'm going to have a temper tantrum. That's it. So it's fun. It's exciting. And then you obviously get young children, 2 to 5 years of age. This gets less important when you're going through the aging process here. But when do they kind of become sort of like adults? We can kind of treat them as an adult from a drug standpoint. Usually around adolescent age. So again, we can have some pretty big, 12-year-olds that are out there that are reaching adult sizes. And the general rule of thumb is, because again, how are we normally dosing a lot of these drugs? Based on weight, right? So again, at what point do you cap that out, though? What point do you not exceed? At what point do you not continue escalating the dose even further? So once they get to an adult dose, you typically want to stop at that point, right? So again, I can have someone, I have a really big, 16-year-old, big football player or something like that. I'm not going to give them a bigger dose than I would give to an adult patient, right? Because again, at that point, they're physiologically almost identical to an adult. Usually around that puberty point is when you can kind of consider them, okay, you're pretty much acting like an adult at this stage. Obviously like a 2-year-old is going to be definitely far different. However, once they kind of get older than that in their teens, like usually you kind of consider them, okay, if you're hitting the adult doses, you're going to get an adult dose essentially. Okay, so lots of different changes occurring here. We're going to look at the different pharmacokinetic aspects of the patient, so the absorption, distribution, metabolism, and excretion, and how this can be affecting lots of different types of drugs here. So going over the kinetics first, looking at absorption of stuff. So again, this can be affected by several different things. So obviously, molecular weight. So do bigger molecules or smaller molecules get absorbed better? Smaller, right? Smaller the better is going to be absorbed there. How about particle size? Smaller, again, okay. Remember pH and pKa? Remember we talked about the Henderson-Hasselbalch equation? Bless you. You guys like try to repress those memories as best you could. Right, so again, pH and pKa is very, very important when talking about weak acids and weak bases and just how well things are going to be absorbed. We'll talk about that briefly here. But then also looking at the dosage form, if we're dealing with a topical product versus an oral product versus an intramuscular product. So we'll look at these in a second here. But based on the physiologic characteristics of the patient and kind of how old they are and how well developed they are, this can affect how well they're going to absorb different things. So looking at gastric absorption first, we're going to find that two of the big things that affect drugs and how well they're absorbed is going to be the gastric acidity and also the gastric emptying time. So if you imagine, say, like gastric acidity, how do you think that changes in like a pediatric patient versus an adult, especially like a neonate? They're producing like a ton of acid, especially if they're premature. Probably not. No, it takes them a little bit of time to kind of ramp up to start producing that. And so you're going to find lots of difference here between like an infant up to an adult patient. So for instance, looking at things that are reliant on pH-dependent passive diffusion, the pH is going to be up pretty significantly in preterm infant. Also, like, what do you think's been kind of going through their GI tract up to the point where they're born? There's amniotic fluid in there, right? So again, that's one of those things where that's going to be amniotic fluid. Do you think is pretty basic, acidic, neutral? Pretty neutral for the most part, right? You don't want the baby cooking in acid or anything like that, but it's pretty neutral for the most part. So again, that's going to be much higher pH though than what your normal stomach contents are at. Like normal stomach pH is what? Normal stomach contents? Should be like 2, right?
I'm thinking blood.
Right. Yeah. Normal blood should be 735, 745, but and that's kind of where the amniotic fluid should also be as well. However, like the stomach should be around 2, right? Because again, we need to start to break down our food. So you're going to find that as the gestational age gets higher, as they get closer to a full-term infant, the gastric acid production should get better, right? Because again, when you're born at 24 weeks, like you're not fully formed yet. Like you should have been cooking for longer potentially. There's usually some reason why you're born early, and so you don't just like show up and be like, okay, well I'm born now, so everything is going to function normally. You still have very immature organs at that point, so it still needs time for that to kind of catch back up. And so you're going to find that typically within the first couple of days or so, as you start to or they've had their GI tract full of amniotic fluid, the pH is probably around 6 to 8. And that can affect things like weak acids, right? Because again, like dissolves like. You guys remember that old adage? Very important here. Weak acids get absorbed better in an acidic medium, right? Weak bases get absorbed better in a basic medium. So if you had a weak acid here, you're going to find they're not going to be absorbed very well. And so you're going to find that usually the highest acid content usually is going to start between 1 to 10 days or so after birth. They're going to start to kind of produce, try to get that pH down. And then about 10 to 30 days or so, it'll start to kind of dip back down a little bit. By 3 months, it should be close to an adult level as far as gastric pH goes. And at that point, gastric absorption is not going to change too much based on the acid content there. So as I mentioned, acidic drugs typically are going to have decreased absorption, but basic drugs should have increased absorption based on that. And again, when you're out there prescribing for these little tykes, you're not going to be necessarily thinking about specifically, well, what's their gastric pH right now? It could come up if you worked in GI potentially, but more importantly, you're going to be looking at drug dosing and things like that, and you're going to understand why it may change between one age of patient versus another, or why I need to make sure that I'm looking at the neonatal dosing versus looking at say the typical pediatric dosing, right? Because all of these things go into that. So when you look at the drug dosing, all that's kind of figured out for you in the reference there, but it's important for you to have that kind of understanding of why those things differ. Okay, looking at GIT or gastrointestinal emptying time, you're going to find that this can affect how well things get absorbed. Typically, it's going to be a lot slower in infants, less than 6 months of age, and they'll kind of start to pick back up over time. You can find different things can affect this. So, for instance, if you have, say, like a congenital heart disease, and you're not able to perfuse your organs appropriately, that will also decrease gastric emptying time as well, because there's not much blood getting there, it's not going to be functioning as well. But things like type of feeding can affect this, gestational age. So things may, depending on the emptying time, if it's very, very quick, things may get past the GI tract before they have time to be absorbed. However, if it's slowed down, you may have more time to absorb things. So this can depend on the type of patient you're dealing with. So again, I mentioned shorter transit time, so things moving faster may decrease that contact time, may decrease the amount of absorption you have there. So if you had like an extended release formulation, you don't see a lot of those in neonates because again, they just have not enough time for that stuff to be absorbed there. And it could account for, though, between patients getting the same dose of drug, how they may change their serum concentrations, because it could be based on how well it got absorbed. So other things, so other routes, because again, we don't give a ton of oral medications, especially like in the very early neonatal period, but certainly as they get older, we'll start to use more oral drug forms. But we do use a lot of intramuscular forms, use a lot of rectal formulations. So looking at, comparing a neonate to a normal infant, say after that first month of life to children, you see lots of different patterns here for absorption. So for instance, muscular blood flow, typically pretty reduced in the neonate. We'll talk about why that is in a second here. But it's pretty increased in infants, and then by the time they're children, they should have normal muscular blood flow. What do you think that's going to affect? What type of drug absorption? Or what route? Probably intramuscular, right? So again, we'll look at why that is in a second here. But mucosal permeability, they are very, very good at absorbing things through the skin and through the mucous membranes, as we'll see, especially when they're neonate, because again, things are very vascular, things are very thin in a lot of cases. They absorb things very well. I don't know if I mentioned the story, but there's one case where I think it was out in California or somewhere where these mothers, if they, or basically they would drug test the children. And if they came back positive for like THC or something, then these children were coming back positive for THC, and they would go back to the mom and be like, well, we're using drugs during pregnancy. I guess like in certain high risk patients, they would drug test them. And so these moms are like, well, I've never smoked pot in my life. Like, why in the heck? Why is my baby showing positive for THC? And there's always kind of social concerns there. And so what they actually found out was that the infants, they're using a certain moisturizer on them, and the moisturizer was actually getting absorbed to some degree, some component of it. And one of the components there was close enough in THC, the chemical structure that actually tripped the assay. It actually tripped the ELISA test and showed positive for THC. So when they tested mom, she was negative. They're like, okay, well, baby's positive, mom's negative, so I don't think the kid's probably lighting up in the nursery. So they linked it back to actually being that moisturizer. So they switched it over to something else, and all the kids were negative at that point. So kids absorb stuff very, very well, and that can go for drugs, it can go for corticosteroids, it can go for antihistamines. Anything can be absorbed very well to that very thin skin. It's very well hydrated, as we'll see. Their body water is very high compared to adults. So looking at intramuscular absorption, you're going to find that you need good blood perfusion to the area, otherwise it will not get absorbed very well, or at least be pretty erratic. And so we're also going to find that the volume of distribution for these little kids are going to be very different because their body water content tends to be a lot bigger. Basically, you're going to find that little neonates, they tend to be kind of big bags of water, essentially, is kind of how we think of them. So a lot of body water compared to an adult patient, not a lot of muscle mass, right? I don't see too many bodybuilding neonates typically, but not a lot of muscle mass, and so their volume distribution changes, especially for those hydrophilic medications. But looking at neonates and infants, they tend to have kind of decreased blood flow to the muscles. They're going to have an increased water content there, so increased apparent volume of distribution for hydrophilic meds, and they're going to have kind of a decreased amount of muscular contractions there, right? So again, if you're not kind of moving your muscles around and using them, that kind of decreases that rate of absorption you can see there. Because again, usually little neonates are maybe kind of flailing their arms a little bit, but they don't really have a lot of purposeful movement there. Other big thing you have to watch out for is they have a lot of peripheral vasomotor instability. So they, sometimes, especially the more immature they are, they tend to have a hard time regulating their body temperature very well, and so you can see some erratic absorption there. That's why you got to put them under heat lamps and things like that to try to keep them warm. So, but rectal absorption is actually very, very good. They have increased bioavailability for some medications over like an adult patient would have. So that's why we like to use things like, acetaminophen suppositories. We use those very commonly for fever in some of these kids, right? Teething pain and things like that. However, you have to make sure they actually keep it in for long enough to actually absorb the drug, because due to increased rectal contractions, and I don't know if you guys know how often a baby poops. It's pretty frequently. I can't wait till my kid gets a little bit older to where I have to change diapers like every 30 minutes, it feels like sometimes. But basically, you have to make sure the drug stays there, because otherwise, if it's not there, it doesn't get absorbed, they poop it right out, right? So one thing to consider. So some other routes. So again, can you get an IV on a neonate? You can, right? It's possible. They have veins just like everyone else. However, is it more difficult? 100%, yeah. It's much more difficult to get an IV on a neonate or a small infant. And so we need other means to get drugs into them, right? So especially if they're in a critical standpoint, they need to get drugs into them fast. So we have things like intraosseous absorption, right? So we have things like Easy IO kit. Have you guys ever seen one of those? Looks like it's like a power drill, a tiny power drill that has like these like thumbtack looking things that have needles on them, and you can go right into the tibia and get really good drug absorption there because the bones are basically big non-compressible veins. You can just inject it right into the marrow and you're set. So it's very good if you need quick drug administration to these patients, but they have a hard time getting an IV. So if they're coding, something like that, this is a very good route to get drugs into the patient there. Now looking at percutaneous absorption, I mentioned that kids typically have a pretty underdeveloped stratum corneum compared to adults. So again, a lot thinner skin, and they also have a lot very well hydrated, well perfused skin. So again, they absorb drugs very well through the skin, which is we don't typically use a lot of topical administration of drugs. Just know that things that get applied to their skin can be absorbed pretty well. So for instance, if you were to give them say povidone iodine, right, usually used as like an antiseptic, that can get absorbed very well. And we saw that if you have too much iodine in the system, what can that do? What organ can that suppress? Yeah, the thyroid. So you can actually see hypothyroidism related back to too much iodine absorption through the skin for these little kids, right? Typical adult, you would not see that. And then also things like, isopropyl alcohol. You couldn't use those on the patients because it actually caused hypoglycemia after they absorbed it, right? So you have to watch out for those sort of things. And I mentioned the volume distribution tends to be pretty different for these kids than you would see for an adult patient. Mainly, their body water content is much higher than you see for an adult. So that means that hydrophilic medications have a very high volume distribution compared to an adult patient, which is important. We're talking about some of the different aspects of drug dosing, which I'll show you some examples here in just a minute. So we're talking about changes in tissue distribution here. But again, if you're looking at total body water, versus very early on in life versus later on, you'll see that typically the body fat's a lot less, their muscle mass is going to be a lot less, but that will tend to usually kind of even out around 1 year of age or so. But again, very early on, tend to have a very high body water content versus fat. So again, looking at this distribution, obviously lipid solubility, plasma protein binding, all these things we know can affect how a drug gets distributed in the body. But again, looking at the body water content is the biggest factor here for these neonates. So looking at a newborn, water content is about 70 to 75% of their body weight. So again, 3/4 of them is water. So the bag of water analogy kind of fits here. And so they also have a very high extracellular water component versus adults, less fat tissue, less muscle tissue. And so in order to achieve the same serum concentrations of a drug, especially of a hydrophilic drug, what do you think I need to do to that dose? So again, if you're looking at a neonate has a high body water content, has a high volume distribution, to get the same serum concentration, something like say gentamicin, what do I need to do to the dose? Do I need to decrease it, increase it? You actually have to increase it. So we're going to find you actually need higher doses of some drugs on a milligram per kilogram basis than you do for adult patients, right? It seems kind of counterintuitive. You think with the little kids I should give less drug, but that's actually not the case because again, it goes back to the kinetics. Again, basically their bucket is a whole lot bigger from a water standpoint than you would see for an adult patient, right? Again, it's fun to put little kids in things they can't get out of, so take lots of pictures when you can do that. I have a few like cardboard boxes my kids like stuck in. It's fun. Yeah, you got to pull them out afterwards, but it's fun. Anyway, so gentamicin is really a good example here. So again, gentamicin is what type of drug? It's an aminoglycoside, right? Use it for what type of infections? Gram positive, negative? Negative, yeah. You can use it for gram positive synergy, but most often you're going to use it for gram negative infections. So the thing here is that we use it a lot for like neonatal sepsis. So if you had a patient who, and again, because like if you have like a little infant coming in with a fever, the question is like, where's the source? And it's hard to really kind of find those things. And the big question is like, is it meningitis? And it's hard to rule that stuff out kind of early on. So oftentimes for early like onset neonatal sepsis, we'll use gentamicin in addition to something like ampicillin. Anyway, so looking at the volume of distribution in liters per kilogram, you see for a neonate it's about 0.5 to 0.6 versus an adult only 0.2 to 0.3. So 2 to 3 times higher the volume of distribution for gentamicin versus an adult patient. So that means in order to get the same serum concentration, because remember, C0 equals dose over VD. Because the VD is bigger, my denominator is bigger. I have to give a bigger dose to get that same initial concentration. So the dose here is about 2 to 3 times higher than you see for the adult. So 4 to 5 milligrams per kilo per dose versus an adult, you only give maybe 1 to 2. And that should achieve the same serum concentrations based on the changes in volume distribution here, right? So again, this is why it's really important to make sure you're looking at, if you're treating someone who's only 2 days old, look at that neonatal dosing thing there. So if you look in Lexicomp, who use Lexicomp for their prescriptions? Or are you like up to date through, you got to Lexicomp through up to date? Right, so they have a neonatal section. a pediatric section, and then use an adult section. Make sure specifically look at the neonatal section if you're dealing with someone who's that young, right? Because again, you're going to differ very greatly from the typical pediatric, 2 or 3 year old. So other things you can find, they're going to have decreased plasma proteins, they're going to have decreased protein binding sites in a lot of cases, which can affect volume distribution. And then also some drugs can actually compete with some endogenous compounds, like things like bilirubin. And in fact, one drug you cannot give to a neonate is ceftriaxone. Remember, ceftriaxone is what type of drug? Cephalosporin. What generation? 3rd generation. So it's really good for treating things like sepsis or meningitis because it has a good broad spectrum coverage. However, we can't use it for these neonates because of the fact that if you were to give it, it would actually compete for bilirubin, displace all that bilirubin, and then what happens? They get jaundiced, right? So again, for the first 20 days, I cannot give ceftriaxone. However, I can give something like cefotaxime, which is another 3rd generation. And so if you had someone who needed to give a cephalosporin to IV neonate, I'd actually give cefotaxime, and then once they're past that month period, then their bilirubin should be down, and I can switch them over to ceftriaxone if I needed to. So one of those little things where, like, specifically, you want to make sure you're using the right drug for the patient because you could find some pretty significant interactions there. Other things like, phenytoin, you may find if you don't have enough albumin levels around, you can have higher free fractions of phenytoin. So even though the level looks good, the fraction that's available to interact with the receptors is a lot higher and can lead to toxicity. So little things you have to consider there. So again, looking at neonates versus infants versus children, you find that like plasma albumin tends to start out pretty reduced compared to as they get a little bit older. So all these things take time though to kind of generate, and again, the more premature they are, the more kind of reduced they're probably going to be in general there. Okay, so then looking at metabolism, what are some things that can affect this? So certainly the bigger the gestational age is and postnatal age, the more likely they are to be able to metabolize things. But certainly you're going to see changes like hepatic blood flow. Have you guys covered anything with like congenital heart disease at all? Right, so you're going to find that like that greatly affects how well you're going to be able to perfuse your organs based on what type of changes you have there. And again, Dr. Levine's a great person to talk to about this stuff because again, she's a PICU doc, right? So she sees all these different types of really sick kids quite a bit, and she can kind of elucidate on a lot of this too. But things like the quantity and quality of enzymes available to actually metabolize things actually will change pretty greatly, and you'll find that everything matures a little bit differently. In some cases, like kids can actually metabolize certain drugs better than adults can, but in other things, you may not be able to metabolize it hardly at all. So all kind of goes back and depends on what you're looking at. We'll show you some examples here in a second. And again, look at if they have an enzyme inducer on board, if they have an enzyme inhibitor on board. Again, keep those drug interactions in mind as well. So again, looking at phase 1 interactions or reactions we're seeing here. Remember, the main goal of metabolism is to do what? Get the drug ready for excretion, usually through where? Usually through the kidneys, right? So again, typically when you're having a phase 1 reaction, this is where CYP enzymes come into play. You're typically trying to make things more water soluble or getting it ready for a phase 2 reaction, right? Because remember, phase 2 reaction where we start to add on stuff like a methyl group or something like that. Again, try to dust off the cobwebs from those the intro to pharm lectures we had, right? Fortunately, they're all on YouTube. You can go back and view them all. Anyway, the oxidation is going to be one of the primary ones we're going to look at here, but certainly other things like reduction, hydrolysis, etc. So what you're going to find is that CYP obviously is still our most important enzyme system, the most important phase 1 reaction we have here in the liver. But you're going to find that the CYP P450 activity for a full-term infant, only about half of what it should be for an adult patient, right, on a weight per weight basis. The more premature they are, the more likely they are to have underdeveloped enzymes, though, and less likely they are to be able to metabolize drugs effectively. Looking at some specific pathways, so for instance, things like oxidation. So for phenytoin, by 1 year of age, they're actually able to metabolize 2 to 5 times faster than they could for an adult patient. So actually, if you were to look at dosing for phenytoin, you actually see it actually goes up at a point on a milligram per kilogram basis for like a 1-year-old, and then as they get older, it'll actually start to go back down, right? Because they're able to ramp up those enzymes very early on in life and can metabolize it very quickly. Other things, it may have a hard time metabolizing in a lot of cases. So, for instance, things like chlorohydrates, kind of an old school sedative we used to use, may find actually kind of slowed metabolism for that, and they actually stick the drug around for a lot longer. So again, it all kind of depends on what their enzyme systems are doing based on how kind of mature they were at birth there. There's actually certain drugs you cannot give to certain patients, or potentially even like certain like preservatives. So for instance, if you ever work in a NICU, it's really important to make sure you use preservative-free IV medications, right? Because certain drugs come IV and they're going to be multi-dose products. They usually have preservatives to make sure they don't have the drugs start to break down or they have bacteria start to grow in them. However, you can't use preservative-filled products for neonates because of there's one in particular called benzyl alcohol. And they can't actually metabolize the benzyl alcohol. They actually end up getting this gasping syndrome that occurs there. It can be potentially fatal. So again, the drug product use can be really important, not just the type of drug, the actual drug itself, but actually what goes in the drug product additionally, right? Because again, if I give, phenytoin to a patient, there's not just phenytoin in that solution. There's other things that are in there as well. Those are things you have to consider. So anyway, again, just some different examples, and again, you don't need to memorize these specifically. Just know that there are changes that occur here, and they're pretty rapid. So, for instance, 2E1 activity, within a few hours of birth starts to get expressed and can increase pretty rapidly. CYP2C families and 3A4 are present within the first month or so, but again, early on, may not really be there in any appreciable amounts there. And in some cases, by the time they're young infants, you may find 3A4 activity levels actually go above what a normal adult would be in some cases, right? It'll eventually balance out, but it can actually have kind of a spike and then go back down to some degree. So it just depends on the patient you're dealing with. But other cases like phase 2 reactions here. So again, we're adding on to groups, so things like sulfation, methylation. It's actually good that some of these pathways are actually ramped up. So for instance, sulfation is a really important pathway for metabolizing Tylenol, right? If you have too much Tylenol on board, what can happen? Yeah, liver damage is the big thing you worry about, right? But kids, they can actually handle a lot of Tylenol compared to an adult patient on a weight per weight basis. So, for instance, when I'm dealing with calls at the poison center and I'm trying to calculate out, they call up and say, "Hey, little Johnny just drank an entire bottle of Tylenol," or "I accidentally gave too much Tylenol to my child." The question is, well, do they need to go to the hospital or not? Do they get a dangerous amount of Tylenol? And so we do the calculations and figure out how much they got. But for instance, like a young child, we can actually get a much higher dose on a milligram per kilogram basis than an adult can before they see problems. So for instance, a kid could get 200 milligrams per kilogram of Tylenol before they would need to have to worry about liver toxicity. An adult may only be able to get 150 milligrams per kilogram. So again, they can get 25% more drug before you really have to worry about their liver because their sulfation pathway is much better than an adult patient would be. Right? So little changes like this that go on, and again, this all influences the drug dosing and frequency and things like that you find in the drug references. You don't have to memorize all this specifically, but just know this goes into why we make those recommendations or what's in those references. So again, looking at specific pathways, we mentioned sulfation and acetaminophen. Things like glucuronide conjugation can actually find that like morphine may be metabolism may be underdeveloped at birth, but it's mature around 3 years of age or so. So morphine may have a increased half-life in these little kids, which could be good in some cases. So for instance, if I guess heard of neonatal abstinence syndrome, you know what that is? What's that? So mom was using opioids during pregnancy, right? Kid was exposed to opioids, and guess what? Mom was addicted. Baby's going to come out addicted too, essentially. And so they come out and they are basically going into withdrawal because they don't have those opioids around anymore, right? So again, they get very irritable. They have a hard time regulating their temperature. They're not feeding well. They're not growing. And so you have to give them opioids basically to replace that. So if I give them morphine, it's a longer half-life. It sticks around for a long time and kind of help to prevent those withdrawal syndromes from happening, right? Do you have a question? Abstinence syndrome, yeah, neonatal abstinence syndrome. So basically, they come out, they're not exposed to that drug anymore, and they have withdrawal effects, basically. Yep. So if you ever work in the NICU somewhere, you'll see quite a few of those kids. Unfortunately, it's kind of sad, but yep. So if you ever see little kids like on methadone or something, it's like, yeah, they're basically addicts coming out of the womb. It's no fault of their own, but it's one of those kind of unfortunate things we see more frequently than you want to. But
so what do you do about those kids?
You have to kind of replace their opioids and give them enough to where they stop withdrawing, and then you kind of gently titrate them down over the course of weeks to months.
So what if it was like an illegal one that's probably not readily available to get to?
Well, an opioid's an opioid, right?
No, I mean like other drugs.
Yeah, so other drugs you may not need to do that necessarily. So like cocaine, if mom's using cocaine the whole time, cocaine is typically a stimulant, right? So what does a withdrawal from cocaine look like?
You're tired.
Yeah, you're pretty tired and stuff. So again, that's not really going to be a big problem. Like these kids, opioids are usually a sedative. When these kids are coming out, they are like screaming their heads off. They are very irritable, very fussy, not eating. Like they need something to calm them down in a lot of cases. That's why we give them opioids to replace that, and then they can titrate down slowly. Yeah, if it was like cocaine, I don't really see a lot of issues with that. It's not as pronounced, I would say, because you don't need as much drugs to kind of help manage that. Yeah. So anyway, Right, so again, that glucuronide conjugation can be important there, but it'll actually develop over time. Here's that benzyl alcohol I mentioned as a preservative. Why you need to use like preservative-free products for those neonates. So you got to watch out. And actually, it's important because benzyl alcohol is the main one. There are other preservatives that are out there, so just because you have to kind of look at the drug product specifically and say, okay, this one's good, this one's not. We do that from the pharmacy standpoint. So if you're ever working in NICU, you could be rest assured that someone's already gone through and figured out what drugs your patients could or could not get to make sure that it's going to be safe for them, right? But it's good to know why they cannot receive that particular product. Okay, so the excretion, this is another big thing. So typically for these little kids, especially the more premature they are, the less well developed their kidneys are going to be. And so trying to estimate their renal function can be really important here. So how do we monitor renal function for these little kids, do you think? Yep, so we can go off urine output, right? So again, we can do things like weigh their diapers. If they have a cath in, we can see how much urine they're actually producing themselves. So again, typically when we're looking at urine output for these little kids, 1 ml per kilo per hour or greater is typically pretty good, right? So again, if they're less than that, that gives us an idea they're not producing enough urine, which could be related to them being immature, could be related to them being maybe not hydrated well enough. Lots of different things could be doing that, but usually goes back to kidney function. Now, how would we measure renal function for an adult patient? We talked about this before, I think. Is there any like lab tests I can do to look at their renal function? Maybe like on a basic metabolic panel. Even in creatinine, right? So usually creatinine is going to be a good idea of like how much creatinine we're holding on. Usually higher creatinine usually means what to renal function? Means lower renal function, right? Because I'm holding on to more of that creatinine and there, I can't excrete it as well, right? So again, we cannot use that as a reliable predictor, especially in neonates when they're first born, because again, when you measure, it's going to be falsely high. Why do you think that might be? Because they have reduced muscle mass, but whose creatinine are you measuring? You actually measure moms, yeah. So for the first couple of days, you actually can't utilize their creatinine because it's going to appear to be like an adult level, even though they don't really have any muscle mass. And so a lot of that has to go back to mom's creatinine being measured because that's what's been circulating in their bloodstream this whole time. As it clear, though, then those start to get much lower. But again, we usually use urine output as our main indicator there, and we will monitor that every day if they're on drugs that are mainly excreted by the kidneys, like gentamicin is a very common one, because we need to make sure they're clearing that drug because they're liable to get the same toxicity as an adult might. So things like nephrotoxicity, ototoxicity, they're just at risk as an adult would be. So looking at the GFR, I mentioned serum creatinine is going to be falsely, basically it's hard to use serum creatinine for that first week of life or so because it's going to be falsely elevated, but we can utilize urine output as a much better kind of indicator there. So typically a good rule of thumb, 1 ml per kilo per hour for a child is a pretty good urine output. They can go several times above that. I've seen 6-8 mLs per kilo per hour, so they can produce a lot of urine in that time frame, but as long as it's better than 1, you're fine. But again, looking at premature infants, you're going to find their GFRs are going to be down. They're not going to have as good a number and quality of glomeruli. They have immature proximal tubules and reduced renal blood flow. So all these things can affect how well they can excrete drugs out of the kidneys there. It's one thing to consider. So again, looking at GFR, if you're actually able to directly measure that, you would see that it was like a term infant versus, say preterm. And again, we usually will, once they get preterm, you kind of classify them based on their weights. So again, think about 1,500 grams. How much is that? It's 1.5 kilograms. How many pounds to a kilogram? 2.2, right? So again, not much more than like 3 pounds. Like, so this is a very small. We had 500 gram little peanuts come out, right? So again, they get very, very tiny. They're very premature at that point, so they don't really have great kidneys. So you can see here that 1 to 2 days, pretty well diminished activity in a very, very small preterm infant versus the term one. Even when they're out, 16 days or so, guess what? That premature infant still would have been cooking even at 16 days out. They still would have been, had they gone to term, they still would be in mom at this point. So again, their function eventually will get back to kind of what a normal level should be, but it takes weeks to months to get close to what an actual term infant is going to be, right? So again, their creatinine clearance is going to be pretty low for a while, and that gets taken into account when you're looking at the dosing for these drugs. So for instance, gentamicin will say, hey, for someone who's born, say, less than 28 weeks, you're going to dose it maybe every 48 hours. If it's less than 32 weeks, you may dose it every 24 hours. And so again, the frequency of how often you're dosing is going to be much different, right? So again, renal function, clearance of the drug will affect how often you're giving a drug in most cases, okay? The volume distribution changes affect the dose we're giving, because they have to give a bigger dose, but we may give it less frequently because they can't clear it as well. So again, just kind of showing you what the GFR looks like for a neonate, maybe about a month old. By the time they're 6 months to 3 years of age, they're at about adult levels. So again, at that point, you don't have to worry about necessarily decreasing your frequency all that too frequently. But the earlier on they are, especially in the NICU, that's where you want to monitor for that specifically. Okay, so again, looking at half-life, because again, how well you can clear a drug directly affects your half-life. If I have lesser renal function for something like gentamicin, what's that going to do to my half-life? It's going to extend it, right? Because again, I can't clear it as well. So looking at this, in a typical adult patient, maybe he has a half-life of 1.5 to 3 hours. That can be extended very, very much in a neonate, say 3 to 11.5 hours. So for like an adult patient, I may give gentamicin every 8 hours, versus for like a neonate, especially depending on how premature they are, I may give it every 24, every 36, every 48 hours potentially, right? Because again, I don't want to give too much because if they can't clear it, it's going to stick around forever. You see that ototoxicity, and how well can you determine hearing in a neonate? It's more difficult than you would see for like an adult patient, right? They can't tell you, hey, everything sounds kind of muffled. Is that normal? They can't tell you that. Or if they could, they're very advanced for their age, and I'd say you probably should do some studies on them or something.
Don't they do those like brain studies?
They do hearing tests, which I have no idea how those actually work. I know they did them on my children when they were first born, but I don't know much about them. They have an audiologist who will come in and do some tests there. But yeah, I guess my kids can hear. I don't know. They don't listen to me, but they can hear. I can tell. Yeah. Yeah, selective hearing is very important for toddlers. Anywho, all I gotta say, my 3-month-old is we call her Buddha baby because she's already like above the 100th percentile for her age. Like her 8-month-old cousin's visiting right now, and he's like 16 pounds, and then like my daughter's like 15 pounds. Like at this point, this is like holy cow, she's 3 months old. So anyway, she's very advanced for age. Anyway, so again, looking at this, you're going to find that tubular secretion reabsorption, which can affect how well drugs are cleared, tends to be diminished, especially in that first year of life or so. So it takes them a little bit of time to kind of develop and get back to close to where normal adult levels are going to be at. Okay, so again, lots of different reasons why these kids may respond differently to certain drugs. So certainly a lot of it goes back to the kinetics of how well they're managing it, how well they are distributing it or excreting, absorbing, all that kind of stuff. But certainly we see a lot of changes that can occur over time. So for instance, you may find that when they hit puberty, things change quite a bit as new hormonal influences can affect how well they're growing, how quickly they're changing. One of the things you always have to consider when you're working in the NICU is like, you're dosing something, say 3 milligrams per kilogram every 24 hours. Okay, so as for instance, well, you can keep that same dose going for several weeks, but guess what's happened to your patient's weight? Presumably it's gone up during that time, so you need to make sure you're readjusting their dose as you go along. And so it's, for an adult patient, hopefully their weight's staying pretty much the same if they're well developed, and you can keep them on the same dose for a good long time, right? Unless their renal function is changing or something. But these little kids, you need to make sure you're kind of going back and reassessing their dose and make sure it's appropriate based on their new weight, right? So, but little things like, pharmacogenetics can be important for certain drugs. We mentioned codeine before. What type of drug is codeine? It's chemically related to, it's on the slide, morphine, right? It's an opioid, right? We use it for pain, use it as an antitussive. But we actually don't use codeine for kids anymore because we actually saw some deaths associated with it, particularly in kids who were going for tonsillectomies and adenoidectomies who had OSA, right? They had obstructive sleep apnea, because some of these kids are actually very good at converting codeine over to morphine because they had a very well-expressed CYP2D6 enzyme. So they converted a ton of this stuff over to morphine, and one of the big side effects of opioids is what? Respiratory depression. And guess what? These kids are already inflamed and swollen. They already had OSA, they're post-surgery. So guess what? Some kids died because of that. So it's one of those things where, like, because of that pharmacogenetic difference, we say, okay, no more codeine. We took it off our formulary. I don't know that any pediatrician really recommends this stuff anymore, but some patients still respond really well to it. So like I know a lot of like sickle cell patients, they tend to respond very well to codeine because they tend to have more 2D6 and they can convert that stuff over very well. It just depends. But now I actually got a black box warning because of that. So that's why I don't recommend it for majority of children anymore. So again, looking at how you're dosing this stuff. So again, looking at codeine, you can do like age-based dosing. You can do things like 2 to 5 years of age, you can do this. If it's 6 to 12, what's kind of the disadvantages of using something like this? Well, if you have a kid who's really big or really small for their age, right? Some of these kids have chronic illnesses or have genetic conditions that make them very undernourished or very small for their age. They may be getting too much dose, right? You have kids that are very large for their age. So for instance, like my little girl, she might be a little bit bigger than some other, 3-month-olds out there, and she may be getting too much of a dose or getting too small of a dose for her weight, right? So there's a lot of issues where weight can affect this. The extremes of weight can affect it pretty decently, and it kind of assumes everyone's acting the same from a kinetic standpoint, which is not always is the case. So again, age-based dosing not used too frequently, but still used occasionally. More often than not, we're using body weight dosing, which is nice because it will take into account what their weight is, right? So that way every patient gets a different dose based on their weight. You've already done a ton of this, right? You've already done quite a few oral liquid prescriptions, maybe Hyset or amoxicillin and things like that. So you guys are pretty well versed at doing those calculations, right? Everyone feel comfortable doing those? Hopefully, yes. Don't see too many heads shaking, but yes, when you go out there and you actually work in pediatric patients, you're going to feel comfortable doing this because you've done the calculations. You can feel rest assured that yes, I can do these calculations, because a lot of people get very hesitant when dealing with kids. They automatically assume that, hey, I'm going to do something, I'm going to screw them up, I'm going to kill them. You're not going to do that. Just get some practice. You've already had some. Feel confident that you know what you're doing. But again, you can still find some kids will not be able to clear drugs as well as others. You may find some issues there. So it may be some cases where this is not super appropriate. However, for the majority of kids, this is a great way to dose them. So again, for especially like extremely overweight kids, you may find there's some cases for underdosing. In some cases, they're very small. You might find some overdosing, but for the most part, you're going to find that body weight dosing is going to be the most reliable one you're going to use for at least most often. One other way you can do it is with body surface area. Remember the advantage of this? What it also incorporates. Then we know what you use to calculate body surface area. Use height. So again, now you're factoring height in addition to weight for the patient, so it makes it so the extremes of weight have less of an influence on there, because usually their height has changed in accordance with that. So we use this a lot for chemo dosing for drugs. So for instance, we might use 1.5 milligrams per meter square of vincristine. That's how we'll come up with our dose for those patients. And so it's much more complicated because you have to do the BSA calculations, which most people use different calculators. But just know it's used for certain instances, not used as often as the body weight dosing is. Okay, so any questions on that? I think I'm going to go ahead and cut it here, and then we'll come back. We'll finish out this section. We'll talk about the geriatrics and whatnot next week, and then try to have a little bit of the time for a review. Any questions? Here we go. All right, I'll see you guys next week, and then that'll be it. We're done.
Now it's one more.